Okay, so also I'll mention startup. So Heather wrote a wonderful book. Okay, so just to let you know, and that's kind of what we're kind of taking information out of her book and doing a very quick overview of maybe some highlights of it. So
and it goes both ways. So the book came about because of what I do and because of my passion. I don't want to use that term in the wrong way, but I'm passionate about medication-related problems in older adults because they're preventable. Just right, you and your family members would be would be part of that education. I've also taught in the gerontology program at the University of Missouri St. Louis, for example. So I've taught others who care for older adults, and that's where the material came for the book, from what I've experienced, from my knowledge, from knowing it needs to get out there, and then the book also feeds my opportunity to spread the word more. So yeah, we'll highlight some of the stuff, but these are concepts that are so important, whether I get the book or not, and I'm just thrilled that it's there together in one volume, so kind of an excuse to talk about it.
yeah. So obviously you're very passionate about this. So tell us what stems behind that. So why are you so passionate about this topic?
It's like the preventability. If as we get older, medications often aren't necessary, right? If I ask you in the room how many of you take medications, I'm guessing just about everyone would raise their hand, right? The problem comes from taking medications, adding on medications more and more, maybe not rethinking, is the medicine still beneficial or helpful for me at this stage of my life? Problems can occur, and we'll talk about some of these medication-related problems in a little bit. But older adults are at risk of problems, and many of them are preventable. Some of the statistics are like 2/3 of problems that can arise from medications, interactions, adverse effects, doses that are too high or too low, for example, could be prevented if. And when the patient, you guys are the end users of the drug therapy, you have a very important role in preventing problems, right? So if I could say to you, we might be able to prevent some issues, hopefully your ears would perk up and that you'd want to lean in and find out how can I prevent them. So it's that preventability and the concern that we overuse medications in this country. And we can talk about why that happens. Because it's pervasive in our culture.
Yeah,
right?
There's got to be a pill for that.
Right. I have an ache or a pain. What can I do? Give me a prescription. And think about just in the media. Think about your television ads, newspaper ads. You're seeing advertisements all the time for the quick fix, right? And as with geriatric medicine, we talk about going slower. Start low, go slow, and also having a pause before we intervene and add drug therapy.
So, slide up here. Older adults, these are more vulnerable, and so talk to us about why that is the case.
So I'll talk you through the slide. Again, these are the causes for why we're at greater risk, and I always like to talk about or highlight that older adults is a special population, just like pediatrics or children are a special healthcare population. So as we get older, we typically use more medications, right? There's a term called polypharmacy, which means taking 5 or more medications. So the more medicines you take, you can imagine, the higher the risk of having an interaction. Makes sense. Higher risk of having a side effect. But there's other nuances that come into play. We also see more physicians. Again, you don't have to raise your hand, but if I were to ask in this room, how many of you see more than 2 doctors, maybe more than 3 doctors who are prescribing for you? We have more and more specialists involved, right? And studies show that the more physicians who are prescribing, the greater the risk of having an adverse event, a side effect, a serious problem. So we have more prescribers involved. And then the next 2 boxes are a little bit complicated, but I talk about these. I have a chapter dedicated to this in my book. our body changes in how we react to the medications and in how we deal with the medications. So with this, I'd like to explain very simply that maybe our kidney functions differently as we get older. It doesn't work as efficiently, and many medicines get out of our body through the kidneys. Maybe you've heard of that already. So we need to think about what's the right dose of a drug for someone who has different kidney function. So there's changes in how the body handles the medication. But the other piece that's really important, and a lot of people don't necessarily appreciate this, we are more sensitive to the effects of medicines as we get older. So that fourth piece is that sensitivity. A medicine that if I would take, I'll use the example of alprazolam or Xanax, something for anxiety or to calm the nerves. A younger person might take that and not feel too much side effect, maybe a little, drowsy or a little bit of sedation. But an older adult might have much more sedation from that, for example. Or a blood pressure medicine, starting with a 10 milligram starting dose of, lisinopril, let's take an example, might be fine for most adults, but in an older adult, maybe someone who also is taking a water pill, that dose might be too high of a starting dose. So we need to start with lower doses often. So because we'll have greater sensitivity. So those side effects can be more pronounced, right? So a drug that might cause sedation would really make someone more drowsy as they're older.
So you use the, what did you say, slow?
Start low, go slow. And that slow medicine approach, but definitely start low doses, and increase them slowly, because it takes time for the body to adjust as well as we get older. So if a physician is used to starting someone on, I'm just going to use generic, 2.5 milligrams of a blood pressure medicine, and then increases it every couple weeks to 5, 10, the older adult might take longer to adjust. So if we increase too quickly, side effects can accumulate and boom, happen all of a sudden. I'm picking on a blood pressure example, but I think we worry most, maybe a little bit more about medicines that work in the brain. So drugs for depression or anxiety or sleep, things like that, we need to be really cautious of. And the last thing I'll just mention quickly, because we may not always think about it, but it really is important. Older adults are not included in clinical drug trials as often as younger persons. So there's different reasons for that, but what's important to recognize is if we do not study a medicine in someone who is 75 or 85 years old, and even today we're having people living to be 100 and older, we don't know the safety and effectiveness of the medicines. Are they just as effective in an 85-year-old person as in a 55-year-old person? Things change, so by not having the research, we don't always know, is this helpful for you? So it's another reason when you go to your doctor and you have an ache or a pain or a symptom or whatever, the doctor wants to prescribe a new medicine. It's important to kind of pause and find out, is it a drug we've been using for a while and maybe we know about how it works in someone who's my age?
Yeah.
Or let's hold off on that for just now, and let's be more cautious before taking a medication.
So one of the things I mentioned to you when we were talking before, I said in reading your newsletter and parts of your books, I noticed that there's a lot of drugs that pertain to maybe I have a special needs grandchild, and then I have one that was born where she's had to have 2 open heart surgeries. Specifically, the special needs one they both have all these different doctors, tons of different doctors. They had a critical care doctor that was the hub that oversaw all of those doctors. Okay, I think because it gets so complicated and everything. And I don't know, it seems like the older we get, the more doctors we have, but we don't have that oversight, yeah.
And you describe a large part of the crux of what we're concerned about when we're subdivided and we have all these specialists involved. I have a colleague who is a pediatric pharmacy specialist, and she started a program, she lives on the East Coast, where it's focusing on the pediatric issues, and it's so parallel. We need the data in children and pediatrics to know what's the right dose, what's the right combination. And when I hear my colleagues' stories about children being overdosed and overtreated and the interactions, it's parallel to what I see in the geriatric population. You mentioned, having a physician being kind of the quarterback, the overseer of all these other physicians. Mm-hmm. It's challenging as we get, for the older adult population, it's hard to find who is the one physician who is kind of overseeing everything. It may not be the primary care physician who is the best suited. You'd think that my internist or my primary care doctor would be the one to oversee all the specialists, which makes sense if that works for you. But I've talked with some patients where maybe their heart condition is the main driver of their other health, their concerns or the focus or something like that. So maybe in that person's situation, the cardiologist might be the one to kind of play quarterback and oversee. What's challenging is you have so many people on that healthcare team, and we talked about that a little bit. Different specialists, but you might have a physical therapist or an occupational therapist, maybe a dietitian or a nutritionist, dentist, etc. But as I work with my clients and talk about geriatrics, you are on your healthcare team also. And it's very important that you recognize that you're part of that conversation about choosing drug therapy, which drug therapy, let's reevaluate my medications. Is there another way to treat my condition besides adding a drug, right? Sometimes there's non-drug ways to help our health. But finding that one physician, if you will, to oversee everything, it's challenging, but if you speak up and kind of work with, maybe it would be your primary care doctor, kind of be part of that team, but make sure all those doctors are really looking at everything everyone is prescribing. I think we're not at that ideal, but that's why you have to keep bringing it up and asking it each visit. Don't assume.
Keep bringing it up. Be your own advocate.
You really have to. And I don't want to be negative, but clearly doctors don't want to change what a prescription that another doctor wrote or started. But in conjunction and talking with that doctor, wouldn't that be nice for the two physicians to figure out what is the best therapy for you? I was talking in one of the groups I spoke with, a patient shared the example where she was the caregiver for her parent, and there was two physicians that would not agree. It was very interesting, where she said the cardiologist says take this dose, the other doctor says don't, and so then who's left in the lurch? The daughter and the patient was really struggling. So I, tried to give them as best advice as I could, but really you can get into very challenging situations, unfortunately, because we're a very subdivided healthcare system. So that's why we've got to do the best we can with the system we have.
Yeah. And I think what I realized with both of my grandchildren is their situations are, those things happen, and it's a little bit unusual, but there are already this placement of these overseers of everything to help coordinate, because not all children need that. So it's very specialized. But all of us are getting older. It's not just a few of us that are getting older out of the bunch. All of us get older and have more doctors and are prescribed more medications.
Right. So you're saying like the pediatrics, we know where the high needs pediatric, where they're getting their care and their service, and you can be more focused there, maybe in the hospital setting or certain clinics. But yes, aging, and that's why part of my passion and why I started my business and then the book to try to help get the word out. I've always focused on, the community dwelling is how we term it. Those of you living in your own homes in the community, so not being in a nursing home or not being in an assisted living facility. There's a risk of falling through the cracks, and I hate to say that, but you're giving your prescriptions to take. You're told a little bit about a diagnosis you might have. Here's your prescription, have a nice day, we'll see you in 3 months or 6 months. So it's being at home on your own without anyone to say, now it's time to take your medications, or this is the proper way to take it, or you don't want to add that Advil to what you're taking here, or a non-prescription medicine. You're kind of doing your own thing at home, right? So the more informed you can be of how to follow the right instructions, what questions to ask. That's a big focus, and what I help people understand is what questions you should be asking in order to prevent those problems, right? To prevent an interaction that could be really dangerous for you, to look for symptoms, things like that.
Okay. So overuse of medications and polypharmacy. So I think you already mentioned what polypharmacy means, but why is that important? And maybe you can go over what it is again, definitions.
Yep. So polypharmacy, there's no specific, there's a generally accepted definition, as I mentioned, of 5 or more medications. But as I always say, it could be 3 or more, it could be 2 or more if you're taking something that is not necessary or it's the wrong dose or something like that. My father, God bless him, he took very few medicines all his life, and he came home from the hospital, this is not an uncommon scenario, on a drug called omeprazole. It decreases stomach acid. You can get it without a prescription, right? And he came home from the hospital on that medicine, and I was purposely home with him shortly after he got home from the hospital. He did not need that medication. It's an example of a drug that often is started in the hospital to prevent ulcers in the hospital setting, and it's often continued once the person comes home when it is no longer needed. Now, some people need it for other reasons, and they're on it before they go into the hospital. That's a different situation. But as an example where, I saw it firsthand with my dad, where this happens, and we know that the data are out there that these proton pump inhibitors are continued unnecessarily. So in my dad's case, even though he was taking, at the time, 3 medicines, it was polypharmacy for him because one was unnecessary. So we talk about the use of multiple medications. So poly meaning multiple, pharmacy referring to the medications. And it can be appropriate if you need everything, right? So if someone has high blood pressure and diabetes and glaucoma and high cholesterol, you might need 4, 5, 6, or 7 medications, and it could be quite appropriate. I talk about heart failure these days, a heart condition where right off the bat, 4 medications is what we consider appropriate treatment, right? So we can get to those high numbers, and it might be appropriate. So as long as there's a valid reason that you need your medication, and it's at the right dose, and it's monitored, and you don't have any side effects, or certainly no serious side effects, right? It's manageable, that polypharmacy is okay. But when we get into the inappropriate, that's the concern that I have, because that means we're taking something that's harmful or not necessary, not clinically warranted, no longer needed. Medications are not intended for life, right? Often they will be continued, but it's important that we regularly reevaluate to make sure it's still needed, because that's where we can get into this inappropriate polypharmacy. And that's where polypharmacy in the health world has a really bad connotation, polypharmacy bad, and this is why. Medication overload is another term that I have up here and I introduce only to say that it's yet another term, a way to refer to this problematic use of medications. And maybe it's more easy to say or think about medication overload rather than inappropriate polypharmacy. No one wants medication overload. I think that's pretty self-understandable, that it's the use of more medications than is necessary, where the risk of harm exceeds the benefit you're getting from drug therapy. Why is it a problem?
Yeah, why is it a problem? What does that impact when you have this situation?
So we all learn from our mothers and going through life, everything has a natural consequence, right? So polypharmacy does have some consequences that we need to be aware of, and why, I guess I put this up as a light to go off to say, let's think about our medications before we keep adding another one, right? So the consequences, the negative, the ripple effects of polypharmacy, if you will. I just started to double check. Adverse drug reactions, I talked about this a little bit before. Adverse drug reactions, and that can be having an allergic reaction, it can be having, the side effects, things like stomach issues, drowsiness. We worry most about a fall, right? Additive effects of medications leading to drowsiness, dizziness. And then a person gets up too quickly in the middle of the night and you fall, and that can be just devastating. So we worry about the adverse drug reactions. Drug interactions, I just alluded to how medicines can have that cumulative effect, so there's a little bit of the interaction there. Drug interactions, you could add a medication, you can be taking, let's say, Eliquis for atrial fibrillation, that fast heart rhythm, and you hurt your knee, so you go to the drugstore and you pick up some Aleve, and you start taking Aleve because you have pain in your knee. Well, now you've increased your risk of bleeding, so that's an example of a really important interaction. Medication adherence, what does that mean? All these terms. Adherence is the same term as compliance. That's our older term is compliance to medications, but adherence is following the instructions.
How many times when you take it, how many to eat with it?
All that details, right? Food or no food. In the morning, at night, same time of day. Using an inhaler properly, right? We have more and more inhaler devices for asthma or COPD or breathing conditions. And each one has to be used in a very specific way, breathing in quickly, breathing in slowly, how you do that. So the medication adherence, but then there's so many stories that I've seen when working with older adults in their homes where they're not following the instructions. Not because their purpose, some people on purpose will say, I don't like the way the drug makes me feel and I'm not taking it properly, but they didn't really look at the bottle, the label, and they didn't realize that it was supposed to be 3 times a day and they've been taking it 2 times a day, or with food versus without food. So that it gets more complicated. It's not that we can't remember to take a medicine as we get older, it's the combination of 5, 6, 10 medications. The last couple of weeks I've been working with clients who take over 26 different prescription and non-prescription. That's a lot of pills to keep track of, right?
I had a just to interject, a client that we're working with right now to help move and sell, and we were talking about a trip that they went on to Europe for a month, and he said he had a carry-on bag full of meds. And how he was, at the airport, he was like, look, I'm not selling this stuff. This is just for me. And they're like, no worry, we see this all the time.
And it's shocking. But that was for duration, right? So you needed to make sure you had it for the time of this trip. It fills up, sure.
Yeah.
When I meet with my clients, it's not uncommon for them to bring a box or a large plastic container of all the pills that they're taking. So it's important to think about that adherence factor. Are you following the instructions? Again, it's a preventable problem. If you each know, just to be more aware, make sure you're really looking at how you're taking it. Healthcare costs, of course, most prescriptions have at least a copay with it. We definitely have Medicare Part D is helping. We have insurance. We have insurance coverage these days for our medications. I think back when I started my career, we didn't have the Medicare Part D, right? That only came about in 2006 or so. But every medication costs something, but also the follow-up visits to make sure you're being monitored appropriately. Maybe you have a side effect, you have to see your doctor for an extra visit, or you're going to the emergency department because of something more serious. So all those healthcare costs come into play because of the cumulative polypharmacy concern. And then the final piece is mortality. And I hate to say that, but studies have shown the more medicines, even if we control for everything, there's that increased risk of death, right? So what are we taking in this prescribing and take more medicines? Is it helping us? And we really, to put the brakes on that medication overload,
So we have a slide up here that says, I only take what my doctor prescribes.
So, why is that not just take what the doctor tells you to prescribe? Why is it important, and what are the questions that
I was like, if I had a nickel for every time someone had said this to me, because there's so much more that goes into taking medicines in a healthy manner than just what the doctor prescribes. I will highlight that physicians who are not geriatric trained may or may not know all those nuances about drug therapy in older adults, and that's something important to think about. Less than 2% of physicians are geriatric trained. I won't say even less than 1%, but very few. Less than 2% of nurse practitioners are geriatric trained, and about 1% of pharmacists are geriatric trained. And it matters because of all that stuff I talked about earlier, why we're at increased risk, the sensitivities to the medicines. Our body handles drugs differently. And if physicians are not attuned to the fact that we need to start low, go slow, and even avoid certain medications, which we'll come to in a little bit, taking just what the doctor prescribed can lead to a problem. Can I share a story about just talking about Richard Simmons? If I can go to someone famous here. You guys remember Richard Simmons, the health guru? He passed away in July of this year, age 76. And the family did a toxicology report. The story is that he felt dizzy the day before his birthday in July. He experienced a dizzy somewhat before. He fell the day before his birthday. And he asked on his birthday, I don't want to go see a doctor, I want to just stay at home on my birthday. And the next morning when his caregiver came back, he was next to his bed on the floor. He had died. And the family did a toxicology report, what medications were in his system. And they were pleased to say there was no illicit drugs, so nothing illegal or whatever. He was only taking what the doctor prescribed. The 3 medicines that they found in his blood were diphenhydramine, which is the generic name of the over-the-counter allergy medicine Benadryl, trazodone, which is it's an antidepressant that's commonly used low dose for sleep for older adults, and the generic of Ambien, Zolpidem. So 3 very common medicines. He was only taking what the doctor prescribed, but those 3 together, my take and my little lesson, I think it's an important story because we all, Richard Simmons, we know him and everything was fine, no issues. Those 3 all contribute to drowsiness, dizziness. The cause related to the cause of his death, what led to his death were those 2 falls. And he had dizziness days, weeks before that, right? So just because you're taking what the doctor prescribes doesn't mean it's fine for you, right? I don't want to throw physicians under the bus. They may not realize what someone else is prescribing. They may not recognize that you're taking the diphenhydramine, Tylenol PM. You can buy this over the counter without a prescription, and it's a very risky drug for older adults. So the Tylenol PM, that's the diphenhydramine piece of it. So there's those nuances, right? And maybe you're taking a dietary supplement in addition that could lead to increased interactions and adverse effects.
Yeah. So you could be adding things that your doctor doesn't prescribe that you think is okay because you can just walk in and buy it on your own, no medical prescription for it, but once you start using that, and it counteracts with other things that you're taking.
It could, right, what else do we do at home? Maybe the glass of wine at night. So all these pieces, I'm trying to be kind here. All these pieces come into play, and then maybe you're taking more than you reckon. You're not adherent, right? You're not following those instructions. Something's too much or too little. So things happen. So I always say, just because you're taking only what the doctor says, that's fine. I have yet to walk into someone's home and walk out saying, there's not a thing I have to say about everything's perfect here, nothing to comment or correct or suggest. And we're talking hundreds if not thousands of patients that I've seen, right? So there's always something that we can look at, even if you're only taking what your doctor prescribes. It's a great place to start. But still, having a medicine review and talking about your medications can often bring out something a nuance that maybe was missed, to where something you can prevent.
So let's talk about if you think you're taking too many medications. So
what's the antidote to this medication overload? And again, I'll just mention briefly, there is appropriate polypharmacy, right? That you're taking what is needed, it's helping you, right dose, all that good stuff. But it's that overload issue where we get into problems, and we have billions and trillions of dollars in healthcare costs, partly because of all this prescribing, and it may not even be helping, it could even be harming. So what's the antidote? A new term, I don't want to overwhelm you, but I want you all to learn something, new phrases. Deprescribing is a term given to the concept of right-sizing the medications, or getting rid of that which is harmful or no longer needed, right? So how do you clean up that medicine list? It's this term called deprescribing. So it's important for me to say, do not stop anything on your own. It's a very planned, careful, thought-out process of what may no longer be needed, or a dose that's too high. And let's develop a plan between the physician and the patient of how we might lower a dose one at a time. We might slowly stop a certain medicine and see how you're doing. When we deprescribe a drug, which means lowering the dose or stopping it completely, it could mean we need to restart it or increase the dose again, but we have to see how you do. And the only way to know that is to do this trial of deprescribing, of pulling back on selected medicines where we think maybe the benefit is minimal, or we definitely see an adverse effect or a side effect, right? So that right sizing. Yeah, and the concept medicines are not intended to be for life. I mentioned that earlier. At some point throughout my 30 years of doing this, I might say, at some point I used to say, well, maybe some medicines have to be perfectly fine. I use the example of levothyroxine, thyroid replacement, right? It's a hormone we naturally make in our body. If you have low thyroid levels, you take a little supplement, and that's okay, right? How can that hurt you? However, there are studies that show if you take too much thyroid and you don't adjust the dose that make it so that it's correct for you, there's an increased risk of heart problems, even dementia over long-term use. So every drug has a little bit of that risk-benefit scale you need to think about. What are the risks versus the benefits? And so we need to be thinking about no medicine is intended for life, certainly with proton pump inhibitors, so that omeprazole or lansoprazole, Prilosec, Nexium, these stomach medicines. For simple reflux symptoms, we should be using those for maybe 8 weeks at a time, certainly when you're using it over the counter. But they're often used for years on end, because we don't realize
my mom,
the issue. Yeah.
that was one of the things that they prescribed it at one point in time, and she just kept on taking it.
And sometimes there are reasons, always these asterisks are out there,
right?
But too often people are continued on it. And then what happens is that once you're on it for several months at a time and you try stopping it, you have acid rebound. So then, I've got my reflux symptoms, they're back, I've got to take my proton pump inhibitor again. And when really we need to taper, there's a specific way to deprescribe or stop that medication. So this deprescribing, my little balance.
Deprescribing is detoxing,
right? In some ways, right?
Yeah.
And it's a journey. So sometimes we need to increase that dose. And there are a lot of barriers. I had that previous slide. Deprescribing is hard. Doctors are afraid to pull back sometimes because no one wants you to have an adverse problem. We don't want something to come back. So there's that hesitation. You sometimes don't want to stop something because you've been taking it for years and I'm comfortable with it, I don't want to touch anything. We don't have the science, so we're working on research of when is it okay to stop a medicine if, a good example is someone who maybe has had intermittent atrial fibrillation, that heart rhythm. Once it's controlled, is it okay to stop that blood thinner? Or is it, there's a heart rhythm drug, for example. When is it okay to stop some medicines? Because these are important reasons why we're taking them, right? You don't want to have a returning heart problem. But we need to work on that literature and the research, and each individual is different, right? So in my triangle here, I just talk about this balance of polypharmacy can be problematic. One of the antidotes or solutions is this deprescribing concept. Ultimately, we want to get to what is termed medication optimization, so that balance of just what you need for as long as you need it at the right dose that's helping you live healthy. We just want to live, and then have a quick end, if you will. But we want to live and enjoy and not be have these little incremental problems, which could be medications, but they're not recognized as a side effect, right? That's the concern. Person-centered care. This is where I want to say what matters most to you is a big part of our decision-making with drug therapy, starting it or even stopping it, right? So how are you doing with your drugs, with the medications you're taking? What are your goals for your health, for being with your grandkids, for taking another trip? And what's your tolerance level for side effect concerns versus wanting to maybe work on lifestyle instead? There's a lot of healthy behavior things we can do and focus more on that might help us decrease the medications we might need.
So medication optimization, what is that?
So I guess I kind of talked ahead of this a little bit, but it's that finding the right balance for you. It's ensuring that the medicines are safe and effective. And maybe we focus too much on, well, the safety piece of not having side effects, but then there's that other half of, is it helping you, right? So that's where we look at, the global research on what we know about medications in a certain condition. But that's, general research population. What matters is each of you and how you're responding to the drug therapy.
Sorry.
Okay. So that person-centered piece, I might be able to tell you what the research said, that most likely this drug is helpful for your condition, but is it helpful for you, Mr. Smith? I worked with a patient once who was, one of his concerns, or I don't even know if it was a major concern from him, but as I'm talking with him in his home, he mentions how he falls. There's no warning sign. It's not like his leg feels weak or he feels dizzy. It's like his leg gives out on him, some kind of a weakness. Very vague, right? And you could chalk it up to, well, you're getting older, which I hate that phrase.
Yeah.
It's not just getting older. None of this is normal, right? I looked at his medications as a pharmacist. That's the lens I'm coming at. So it's important to when we talk about physicians and why just because you're taking only what the doctor tells you, the doctor isn't seeing things from the other lens of the combination of the drugs and that type of thing. So anyhow, he was taking a very high dose of the cholesterol lowering medication, rosuvastatin or Crestor. And these medications can cause this vague side effect of weakness, if you will. They can have muscle-related side effects. Not super common, but when you have an older adult on other medications who's on a high dose of this statin, cholesterol-lowering medication, he's having this symptom of falling. My radar went off to think, let's try reducing that dose. Does he need that high dose at this point in his career, or his life, rather, in light of other issues going on with him, right? So it's an example of where we can re-look at something that was probably serving him well for many years with lowering cholesterol, but can we lower that dose? And that's part of that deprescribing concept, lowering the dose. So, and so and also with the optimization, it might mean adding something. If you have osteoporosis, thinned bones, weakened bones, and you're not taking calcium either through your diet or supplement to get enough calcium to help build your bone, we're under-treating something, so we might need to add something. So, risk and benefit, I know I talked about that a little bit already, but so if any questions about that, we can come back to it.
So let's talk about the over-the-counter products. Are they safe? Concerns and.
So this is a great topic. So I appreciate us spending a little time on over-the-counter, as well as I don't have them on here, but I just want to make sure we pull into the conversation dietary supplements, so we can talk about that maybe in the Q&A part. These are all together the non-prescription medicines. You can go into the store and pull them off the shelf yourself and walk out, buy it, walk out, take them on your own. There are some over-the-counter products. Over-the-counter, because technically it's a certain category of our non-prescriptions, where these are regulated as drugs, which is good. So we have good data on them. Things like aspirin, acetaminophen, your indigestion medicines, cough and cold products, those are all your over-the-counter products. So what to use with caution. So just some things to get the conversation started. These are actually, we worry about it. So acetaminophen, Tylenol, too much can lead to liver damage. Why is Tylenol a really good example to bring up? It is found in over 600 different products, over the counter as well as prescription products. So do you think it's easy to maybe get acetaminophen, that word you may not even know to look for on the label, from 3 or 4 different products you have at home? It's possible, right? If you're taking and I've, again, seen so many examples. You've got the Tylenol you're taking for pain during the day. You have Tylenol PM you're taking to help you sleep at night. And then you've got the, I don't know, there's cough and cold preparation that has acetaminophen in it for your, the sniffles that you've been having or something. So it's unfortunately too easy to get too much acetaminophen. So we worry about that because of the liver damage. Aspirin is a concern because of the bleeding risk. And there's lots of times I'll be in someone's home, I go through all of their medicines, and at the end I always pause to ask, anything else you're taking without a prescription at night, as needed? Aspirin, vitamins? Oh yeah, I take aspirin every day. And I'm always surprised when people don't realize that aspirin has some serious benefit. It's a drug and some risk in there, and the bleed. So we worry about bleeding with aspirin. When you need it, you need it, and the benefit is greater than that risk, but we have to think about the bleeding. And when you're combining it with other things, it can be a concern. Antihistamines. So these are drugs we use for allergies. I mentioned Benadryl is a real common older antihistamine. But these older medicines, so diphenhydramine is a great example of in this category. I don't have the generic names up here. Doxylamine, again, I have stories on stories about StephanieParson. These medicines are, these older antihistamines are cough and cold products, but also this Tylenol PM, I mentioned that earlier, Unisom, something that's out there for sleep, right? How many of us complain about having sleep issues, and maybe you're taking these. These are not great choices as we get older because of the risk not only of dry mouth and constipation, but memory issues and confusion. On its own, maybe not, but the risk is there, but certainly if you're taking it over time or you have other medicines that can have a similar side effect. Kind of complicated to get into that now, but we worry about that. I was working with a client who the daughter was worried about drowsiness she was seeing in her mother, falling, and it wasn't until we got through all of her medicines, I'm staring at this over-the-counter bottle, a liquid bottle on her table, and I'm always crying with, may I look? And it had doxylamine. Doxylamine is one of these antihistamines. She was taking it 3 times a day because she had a cough. And her doctor would never have known. Her daughter didn't even pay attention to it. I'm sure that was what was contributing to her drowsiness, dizziness, and the falling, right? But so it's really important to be aware of. So what's an easy answer is make sure you talk to your pharmacist before you purchase some of these products. Non-steroidal anti-inflammatories, Advil and Aleve, ibuprofen and naproxen are the most common ones. Those cause not only bleeding risks, but stomach problems, stomach irritation. So we worry about that, even kidney injury and heart. So there's like a trifecta with stomach, heart, and kidney. Supervised use with your doctor knowing about it short term can be okay, but adding it on yourself can be problematic. And then we've talked about these proton pump inhibitors already, those drugs for the reflux and acid production. Watching the time here, so
Yeah.
dietary supplements.
Yeah. Okay.
So,
Right, there's something, yeah. So, are they safe, and what are concerns, and how people can be safe, and what they can do to be safe in using
So
them?
here I'd forgotten the slides, which slide, so here we are, I wanted to make sure we talk about it. Dietary supplements, regulated as foods, not as drugs. And that's an important differentiation. Why? Because any manufacturer can put a dietary supplement out on the pharmacy shelf or the GNC shelf or wherever to sell the
So
supplements.
tell us about some of these dietary.
What are they?
I'm like, dietary supplement is that not just an over-the-counter?
Right, so again, over-the-counter, the previous slide, those are all regulated as drugs, so we know there's quality control, you know when you take aspirin or Aleve, you're getting exactly what's in there. Regulated as food, dietary supplements, things like fish oil, vitamins even technically are supplements, glucosamine chondroitin, garlic, echinacea, I'm trying to think of some of the common ones these days, valerian people might have heard of, things like that, okay? So the government can only remove a supplement from the market if it's found, once it's already on the shelf, first of all, and if it's found to be harmful. And we've had some recalls. The FDA will recall a certain supplement, but we're relying on the manufacturer to pull it off of the shelves as well. Some of these supplements can contain other ingredients that are not on the label. Some have been found to contain drugs, medications in them. So it's a little bit of a buyer beware world. So we just need to be careful of mislabeled products, knowing that they're less regulated. So
they don't fall under the same regulations as drugs, so they don't go through
they're not. There's no studies that have to. There's no studies that have to be done to show that they're safe or effective. Right? In contrast, every medication, OTC or prescription, we know there's safety and effectiveness data on those drugs. But foods, dietary supplements, is kind of a buyer beware Wild West world. So I would advise people to purchase at your pharmacy. So I like to think our pharmacies are stocking more qualified manufacturers. Look for an expiration date and a lot number that kind of indicates that we've got some quality control on those supplements. So yeah, so safe selection. So we don't have the studies. Older adults typically are not included. I mentioned for drug therapy, we don't have older adults involved. Do you think any manufacturer of a dietary supplement is specifically seeking older adults? We are like fish oil. There's certain places we do have some studies, but it's just more sporadic. Interactions. So I just put some things on here to spark your mind, spark your brain. If you are taking St. John's wort or valerian, garlic, ginseng, those can have interactions with other medications. So these are drugs in the concept, but they're not regulated as drugs by the government. And then that lot number and expiration date, so yeah, I'm getting ahead of myself.
All right.
My favorite topic.
Okay, all right.
That's what we have time, so you got it. So drugs that are considered potentially inappropriate, and this is where I don't want to scare everybody and have you walk out going, oh my God, but I want to share the concept that there is a list of medications that geriatric experts have put together to say, we really need to think more carefully about these drugs in older adults before prescribing them. They can be used in older persons, but it's just a matter of thinking about the risks and benefits and is there a safer alternative. So some of these are the, it's okay, but no, pause here, I think I have one more, but yeah, so go back one more. We'll just,
No, forward.
this one here.
This one. No, that one.
Pause here, yeah, these are, we're so confusing here, so sorry. I just want to make sure I touch on these. So these are these were taken from another presentation. So this is one highlighting some of those potentially inappropriate. They were on my previous slide though, about the OTC products. So we talked about those older antihistamines, why they're concerned because of the memory and confusion piece. And I can honestly say I don't know that every physician will know that we have that potential confusion risk with some of these medications. The proton pump inhibitors we talked about, the NSAIDs and the aspirin. Aspirin to prevent a first stroke or heart attack is no longer recommended. So this has changed over time, and I want to be clear here, again, every advice, I don't want to mislead people. If you have had a stroke or heart attack, aspirin is extremely valuable. It's this looking at preventing for the first time. It has to be looked at very individually for each person, but 20 years ago, the theory was once you hit 50 or 60, everyone should be taking an aspirin to prevent a problem. And that's changed over time. So another great example, Stephanie, of why over time we need to relook at our medications and make sure the data, our medication regimen is up to date with what we know from research and stuff. So let's go back to that next slide so we can make sure we leave time for question and answer. But these are prescription medications, and I think I have a couple slides on these. Just again, not to scare people. If you see a medicine that you might be taking, it's just something you might want to go back to your doctor and ask them about. Make sure it's the right dose and still necessary for you. We worry about benzodiazepines and related drugs called non-benzodiazepines for sleep. I have some examples written up here: Xanax, Ambien, Sonata. Ambien was the example I used that Richard Simmons was one of the ones he was taking. But we worry about fall risk with these medications. We worry about memory decrease with these medications, right? So when someone comes to me and they're concerned about changes in their memory, I'm looking for these kinds of drugs that they might be taking. Muscle relaxants is another group of medications we know we should use really with caution, if at all, in older adults. So there's the risk of the grogginess or confusion, the fall risk. Again, we really worry about that. And looking at what we know in older persons, right? 65, 75, 85, there's minimal benefit of these medications, right? So I can use the example, my father had a back problem, pain in his back. The doctor prescribed one of the muscle relaxants for him. And that led to him feeling more drowsy, more dizzy. He fell out of bed at one point. And this is a man who was super healthy and strong all his life. So these medications can be detrimental with minimal benefit. And then we worry about certain medicines that can cause low blood sugar. So very few drugs are highlighted here. Can they be used? Sure. But is it important for you if you are prescribed that medicine to know that we need to make sure we avoid low blood sugars when you take this? Make sure you eat on a regular basis. This is what we do to prevent problems. So that preventability comes into play.
So yeah, I can say, looking at that previous list, I know my mom was prescribed like many of those.
Right.
So I went back and I'm like, okay, why is she taking this? And does she really need to take it any longer? And we actually ended up eliminating quite a few.
I'm glad
she
you
did fine.
And it's just questioning it, right? The physicians, there's a term called prescribing inertia, meaning we just keep renewing the prescription, we'll continue it, and just keep it going, that inertia.
Yeah. Why did she take this? Well, she came in and was already taking that, and so we just carried forward.
Right, doctors, you switch doctors, right? So doctors say they inherit someone else's patient, and I'm not going to touch anything right now, and maybe not at first, but you really need to always re-look at everything.
And going into the hospital, she'd go into the hospital, they would add some things on, and she would come out, and they would just carry forward those when those weren't meant to be taken all the time.
Those PPI drugs is a great example of something that's continued. Proton pump inhibitors for the stomach.
That was one of them.
So it's a great example. And it's a good segue here. So I think the next couple slides are about those take-home tips and strategies. And I don't want to I want to raise the alarm appropriately, just be aware of your medicines, but I also want to give you some great tools to help you prevent those problems and be safer. So the medication list is huge. You got to keep it up to date though. And I want to include the key information, why you're taking it. And if you've got a hole in it, like maybe with your mom, there's that question of why is she taking this? That's a great place to start with asking a question of your healthcare team, your pharmacist or physician. Because maybe it may no longer be needed. Write down the prescriber name and when it was started. And I really emphasize that more these days, especially when it comes to looking at what we could stop. If you don't know who started it or when it was started, there's that hesitation of, can we lower the dose or possibly stop that
So
medicine.
prescriber name meaning the doctor.
Who started it for you, right? The physician who prescribed that initially. Worked with a patient who he was on, I'm trying to think which drug it was. It was a heart-related drug, but he said, oh, I started that 3 years ago after I had a certain surgery. And so likely it was no longer needed. But that piece of information was helpful to help us hone in on, could we look at stopping that medicine? So, and share it with every care provider at every visit, every encounter certainly before something's prescribed. What I am concerned about is that people look at the medicine list and it looks fine, and you're walking and talking, so you seem to be okay, but they're not looking deeper at the potential incremental benefit, the additive risks, that type of thing. So,
Okay, all right. Anything else that you
memorize this one, we'll have a quiz on it in a minute. So I talk about things you should know, and yes, 8 is an awful lot. They're probably prioritized, but recognize that your drugs, what should you know about your medicines? Basic things. Recognize there's 2 names for your medications. And I've seen people have gotten into trouble because they didn't realize that diltiazem and cardizem were the same medication, or Synthroid and levothyroxine. Again, I've seen so many stories where these preventable errors are there. The preventable errors are present. Could we have prevented them? So again, just know a little bit about your medicines. Why are you taking it? Those instructions for the adherence piece, and then down the list, I can come back to app it.
All right, well, so those are great tips. I saw someone taking a picture, so we can also get you slides if anybody wants to have the actual slides. You can let us know. So, you ready to open it up for questions?
Yeah, and I was just, I guess, wrapping up this, how do you know, there's so much up here, but what do you do? If you miss a dose, how long do you have to take it? Do I need refills? What's a serious side effect? How many of you get that paper with your medication that's all about yay long, right, of side effects and things like that? You want to ask what's important for you, what's most common. But I just want to share the point, when you're at the pharmacy counter and someone, usually the sales clerk is asking, any questions for the pharmacist? Say yes. Ask. You don't know what you don't know. Even if you've been taking it for 20 years, again, I've seen it where someone didn't realize it was once a day, they were taking it twice a day, or whatever it might have been.
And they make it in fine print, so it's hard to read,
yeah.
and it's easy to,
Miss something or
misread a dose or something on there,
Absolutely, yeah.
but I know you mentioned before, pharmacists want questions, and I know it's like, no, I'm good, I don't have any questions. I haven't even read anything about it yet, so.
And you don't know what you don't know in that case, for sure, right? Pharmacists are trained to communicate. We're educators, and we want nothing more than to help you understand your medications. It's a lot more fun than dealing with prior authorization and insurance issues and all that stuff. So even though, and people typically say, I don't want to bother the pharmacist, they look so busy and all. What's more important than your health and knowing what you need to know? And hopefully you've gotten the idea that you don't know what you don't know, or just knowing a little bit more can help prevent some of these problems. So that would make it worth your time to ask to speak with a pharmacist when you pick up your prescription or a refill.